Hello, everyone, and welcome to today's webinar, a trauma-informed care approach to healthcare providers' interactions with families and friends of homicide victims. My name is Susan Howley, and I'm the Program Director for the Center for Victim Research. The research being reported on today, as well as the Center for Victim Research and this webinar, are all supported by funding from the Office for Victims of Crime at the U.S. Department of Justice. The Center for Victim Research is funded to provide a one-stop resource for victim service providers and researchers to improve access to victim research and data and improve the utility of research and data collection to improve crime victim services and response nationwide. The Center is a partnership of researchers and practitioners at three principal organizations: the Justice Research and Statistics Association, the National Center for Victims of Crime, and the Urban Institute. And now it is my pleasure to welcome today's presenters. Dr. Gina Mastrosinke, who's an assistant professor in the Department of Law and Justice Studies at Rowan University, and she partnered with Dr. Elizabeth Chercheo, who's an associate professor of medicine at Cooper Medical School, also at Rowan University. And with that, I'll turn it over to them. Welcome.
Hi, everyone. Thank you so much for your participation today. I do want to start by thanking the Center for Victim Research for the opportunity for Dr. Chercheo and I to be able to present these findings, and also for the funding supporting this research as well. I don't want this information to get lost towards the end of the presentation, but I do want to thank up front also for the families and friends of homicide victims who have been willing to participate in this research and share their stories with us so that we're able to move towards a more research-informed response for families affected by homicide. I wanted to start by talking about our research team. We have a very interdisciplinary research team. It's quite diverse. We will talk about the benefits of this towards the end of the presentation, but this is just an incredible team that's very dedicated to this topic and to trying to help people who are affected by homicide. Regina Boylan was our research assistant on this project. She is pursuing research and her studies, graduate studies right now at Immaculata University. She was at Rowan before this. Dr. Chercheo, who is the co-presenter on this work as well. Dr. Wanda Foglia, who's a JD PhD. She's a faculty member over at Rowan University in Law and Justice Studies, as well as Dr. Metzger. Dr. Jed Metzger is a professor in social work department over at Nazareth College, and Mr. Peter Navratil, who is a co-owner of Tree of Hope Counseling. So you could just see from the research team just everybody's diverse background and perspectives that they're bringing to this project. Our objectives for today are to understand the health effects for families and friends of homicide victims. We also are going to discuss about experiences that people have with the health systems. Health system is pretty broadly defined here, so we're also discussing mental health services, people who are first responders, and also discussing people in the medical field as well in various specialties of medicine. We are going to discuss the trauma-informed framework and how our work wound up coding onto that. Additional themes that came up in our study that didn't necessarily fit in the framework itself, but they were prevalent themes that we wanted to discuss. Our suggestions for providers as well, and then we'll end this by discussing about the benefits of working with an interdisciplinary researcher practitioner team. I do want to start by talking about the extent of the problem. This is always a really powerful chart to look at. These are the most recent statistics that are finalized through the CDC, looking at the 10 leading causes of death by age group. So you could see in this chart that you're looking at that for ages 1 to the group of age 35 to 44, that homicide is one of the leading causes of death. It's one of the top 5. We see between 15 and 24 and 25 and 34, it's up to the third leading cause of death. So behind each one of these numbers, we don't know how many family members are affected, how many friends are affected, how many communities are affected, and it's important to understand that and how many people have been affected by homicide. And again, in the context of this talk, people who are seeking help through people in the healthcare field. A lot of times when I talk about this too, I'll show a picture of a ripple effect in a lake. I think that usually shows a really good illustration of how a homicide occurs and how much it goes through communities and how many people are really affected by it. So the statistics that we have is that it's roughly estimated that every homicide affects about 10 people. Also that there's limited research understanding the needs of family and friends of homicide victims, the resulting health effects, their experiences also with response systems. And response systems, we discussed that in this work. We're including criminal justice system, health systems, also spiritual systems. We'll talk a little bit about the educational system as well. These are issues that we know that people who have experienced the homicide of a loved one are facing. And in addition to this too, one of the key points of this presentation is that we have people who are presenting to healthcare providers with health issues when, in fact, this could be related to an underlying trauma of having a family member who is killed by homicide.
So I'm going to go into a little bit of the effects of trauma, which we're only now starting to develop a more nuanced appreciation of. There is now emerging research that provides a biochemical basis for some of the effects of trauma, and this could be a talk just in and of itself, but there's alterations in function of the limbic system, of the endogenous opioid system. If we're thinking about all of the numerous, all the interplay between endocrinologic, between hormone systems, we can think about the HPA axis, the hypothalamus pituitary adrenal axis, and its role in cortisol production. The sympathetic and the parasympathetic autonomic nervous systems are also very entwined in this process. If you're thinking about the sympathetic nervous system, that's the fight or flight response that people have that can just stay in a chronically ramped up state. We even see brain remodeling. So there can be neuronal remodeling or loss in the limbic system, in the hippocampus. And there's also change in the inflammatory mediators. And some of this is, again, mediated by some of that stress response. But we will see accelerated atherosclerosis. You will see metabolic syndrome where you can have hyperglycemia, hyperlipidemia. So you have these patients with cholesterol issues and as well as chronic pain and chronic fatigue. So there's this very, very complex interplay that can be purely the result of trauma. Some of this was actually explored with a very large survey, the Adverse Childhood Experiences Study. This was done in Southern California, was through the Kaiser Permanente system, but also with the CDC. And it was really one of the largest investigations of childhood abuse and neglect and household challenges. And it tied it to later life health and wellness. So this was back in the late 90s, 95 to 97, that they gave these confidential questionnaires to about 17,000 patients. And it was shocking how many people did have some type of adverse childhood experience, but 2/3 had at least one. And there were around 20% of the respondents had more than 3 adverse childhood experiences. And this could be anything from divorce to death in the family to food insecurity, housing insecurity, to sexual abuse, physical abuse. So it was really a very all-encompassing study. But from that, we were able to make some of the linkages with health outcomes in later life, in adulthood. And that ties in with the allostatic load. It's a concept that was originally describing the cardiovascular system. So allostasis is literally maintaining stability through change. So it's describing this process of accommodation and adjustment to outside challenges and stress. But there's a cost of that chronic exposure to a fluctuating neural and endocrine response. And so that allostatic load definitely comes into play. And we know that the poor suffer worse health outcomes and increased mortality than those who are middle class, who are lower down than people who are very wealthy. And that is not just based on access to care. So there's a lot of other interplay of systems that go into that. So just calling it stress is an oversimplification. All of this does really have a lot of broader implications.
So in addition to the trauma that Dr. Chercheo is speaking about and about the effects of trauma that she's been discussing, there's also previous research. This is a study that I was involved in, 2 different studies, where we're looking at health outcomes in the terms of the biopsychosocial model. Those of you who are familiar with this model, if you are not, basically this is a model that Engel had brought up in the 70s, saying that in addition to what we think of as medicine and being your general blood draw, for example, things that we should be looking at with health include psychological effects, social effects, and also the biological effects that people have. In our studies that we have done, we've added spiritual effects, which is why we're also discussing spiritual responses, because that's something that came up for a lot of people in our group. So we had modified this model in previous studies. Additional research, too, that looks at health consequences. Now, this is specifically for families who have been affected by homicide. There's consequences that are showing up with depression, eating disorders, insomnia, post-traumatic stress disorder, substance abuse, and suicide ideation. So when people are in healthcare provision, you can have somebody coming to you discussing things like depression, I'm having a hard time sleeping, and if the physicians are not, or the healthcare provider is not asking about any trauma, they might not know about this homicide that occurred in the family, yet this person's presenting with these issues to the healthcare provider.
As Dr. Master-Sinclair was alluding to, these are all conditions that physicians will see very, very commonly. I'm just going to dive into the PTSD category, because it's very common to have primary care patients present, and they may be unrecognized as having PTSD, where the provider may not have even uncovered that there was underlying trauma. But a lot of people in this population can present with markedly elevated rate of somatic complaints, and that can sometimes be misattributed, and a deeper dive doesn't necessarily happen. So somatization, which is what we used to call it, it's now called somatic symptom disorder in the DSM-5. There's a lot of explanations trying to advance what this comes from, and again, it goes back to that idea of allostatic load and of allostasis, that this may be a result of the body's attempt to cope with emotional and psychologic stress. But the thought is that we only have a finite capacity to cope with this stress, and then beyond a certain point, people will start to experience symptoms, physical symptoms, a lot of times gastrointestinal or neurologic headaches, or genitourinary chronic pain, IBS, anxiety. So there's a lot of comorbidities that are pulled into this group of patients with PTSD that we really need to consider. And again, as we talked about, the biochemical basis, trauma exposure, and PTSD can increase the risk for such things as cardiovascular disease. This is one citation, but there are numerous other citations supporting this type of outcome from trauma. The concerns for the healthcare providers, there's a very entangled interaction among factors, and it's incumbent upon us as physicians or healthcare providers to try to untangle some of this and understand that patients may be presenting with conditions rooted in trauma. But again, it's very complicated. So patients will have more somatic symptoms, more mood and emotional disorders, and these patients also have more organic disease for all the reasons that we just discussed. So that a middle-aged woman could be coming in with fatigue and shortness of breath. She could be having anxiety, or it could be a heart attack because she's having accelerated atherosclerosis and hypertension from a ramped up sympathetic nervous system and cortisol over-secretion. So there's difficulty in attribution of symptoms. And there's the physician's concern, too, about what we do with this information. So we do our due diligence, and we rule out the heart attack. We try to make sure that we're ruling out any organic basis for a presentation. But then there's a lot of concern on the part of physicians about when we start asking the questions, how are we going to help? We're a very evidence-based practice, and so we like to do things that have an evidence-based answer to it. And trying to get to the root of people's experience of trauma and perhaps the death of a loved one doesn't have an easy answer. So we're very worried about what happens when we open Pandora's box. And there's also concern about making the situation worse, about re-traumatization, because we're not therapists. We don't necessarily have an hour to devote to each patient, and we don't want to make things worse, especially if we don't have the resources after that encounter to be able to connect that individual with. So, and this applies to advanced practice providers and nurses. It's really endemic throughout the healthcare system.
So the current research that we did was to hold focus groups with families and friends of homicide victims. This is a research practitioner partnership. For the recruiting, essentially we did a lot of putting up flyers, listservs, contacting people in the community organizations as well. I will discuss the analysis a bit later. Our focus groups here were focused on understanding people's health consequences, their experiences also with the health system and healthcare providers. We had 3 focus groups. It was in total 11 people. That might seem like a small number. That's actually really consistent with a lot of the other studies that we have done in this area. The groups were held in Pennsylvania and in New Jersey, and participants were asked about their experiences with the criminal justice health and other response systems, such as the spiritual response system as well. To let you see what our sample looked like, we had 11 people, again, who participated in these groups. We had asked people to self-identify on gender, race, and ethnicity. You could see the numbers in front of you as far as the people who participated in this group, and you could see as well the average age of people who participated was 46.7. We had largely female population as well. 6 people identified as being Black. We have also here about the marital status, kind of split between people who are single and people who are divorced, separated, people who are married or partnered, and you could see the employment also outside the home, in addition to the highest education level that was attained. We also asked people about their loved ones' demographics as well. So for the people that they came to speak about their loved one, it was an overwhelmingly large population of males who were killed. And again, we asked people to identify on race and ethnicity. 8 people who had the people who had participated, 8 of their loved ones identified them as being Black, and the average age was 26.5. This is really interesting because it matches up with the statistics that we saw before from the CDC. Many people coming to speak about a child that was killed. We also have either a spouse or a partner, a sibling, 2 people who came to speak about a friend, and 1 about a cousin. Our methods on this project, it wound up being that we audio recorded the focus groups. These were transcribed, and then the team members wound up getting the Word document from the transcription. We had gone through those, and then we decided on what themes were emerging. We selected the TraumaInformed Care framework, and then individually we had coded our transcripts based on this framework. Then we had a series of meetings to discuss consensus, to see if we all had coded the same way. We also had these additional themes that were identified, I'll talk about in a few minutes. And also, we had consensus at some point that we had agreed as a group that we didn't need to hold additional focus groups. So I'm going to start with what might trauma-informed care look like. So this is essentially things that worked for people, things that were based on the framework that I'll talk about in 1 second. Those of you who are providers, who interact with people who are families and friends of homicide victims, I think one of the big things I always talk about in doing this work is that you are a part of the memory. So there are people who will talk about remembering the responder and what they did, or it could be law enforcement, it could be one of the physicians, a mental health counselor. So that becomes a really important part of that person's memory of what occurred after the death of their loved one. There's a great quote here, too, that says, trauma-informed care requires a system to make a paradigm shift from asking what is wrong with this person to what has happened to this person. And you'll hear this theme a lot in providers really understanding the history. And as Dr. Traumainformed was saying, too, if you have somebody presenting in an office with health issues, there could be an underlying issue and a larger history that would be very helpful for physicians to be able to identify, service providers to be able to identify, to be able to better tailor the response as well. For those of you who know of trauma-informed care, this will look familiar. It's from the Substance Abuse and Mental Health Services Administration. So essentially, SAMHSA had put forth these principles of trauma-informed care. So how do we go about trauma-informed care? The principles that they had mentioned are things like safety, making sure that the person that you're with, that they are feeling safe with you. As you can imagine, this is going to open up a lot more of a dialogue with the providers. Trustworthy and transparency, peer support and mutual self-help, collaboration and mutuality, empowerment, voice, and choice, and then also this idea about cultural, historical, and gender issues as well. So what I'm going to do is actually go through some of the quotes that we have from some of the participants in our study that illustrate each one of these points. So for safety, we had somebody in one of our groups that said that they had a provider who was somebody who consistently was reaching out and pursuing them to try to help them, try to connect them up with resources. This was something that the person very much appreciated and said, the fact that he cared enough and kept pursuing me, I eventually opened up to him. We have here trustworthiness and transparency. Anybody who works with anybody affected by victimization, it's very common that getting information is very helpful for people, knowing what's going on with their court cases, knowing who the different actors are in the system, for example. So we had one person who their loved one was killed, but after the homicide occurred, they were being given information about what the physicians were trying to do, so what the providers were trying to do. At one point they said, we're working on this person, and we had the participants said, it felt good that they told me that they were working on him, so they have information in knowing what's going on. Other things that are important to people are about cases, is anybody paying attention to their case, especially when we're talking about the criminal justice system and also understanding the process as well. We have also this aspect about peer support and mutual self-help. So there are people who are able to connect with other families and friends of homicide victims. This is so key. This was not only in this project, but also other projects I've done, that people want to meet other people like them who understand their shared experience. Anybody who is a provider in this field as well, it might be very helpful just to know of available resources in your area, and those could be in a variety of different settings as well. We had somebody who said, we all share something in common, so if I want to scream and holler, won't anybody look at me strange, because we all share the same thing and we're allowed to do whatever we want to do and we won't be judged. And nobody won't ask us, you still mourning for your loved one. Big issue with the grieving process. There are people who will have some type of idea about a timeline and be critical about that for families and friends of homicide victims. So when they're with other people who have had the same experience, that's very helpful to have that type of support. Also, we had somebody who has the education and all the alphabet behind their name is good, that's good, but I need someone who has either been through that situation or they're empathetic and they don't use their letters to dictate our conversation. Empathy is a theme you'll hear a lot. I think, in my opinion, a lot of families and friends of homicide victims very much appreciate people making an effort, people being genuine about that effort, letting people speak, share their experiences. So those were all things that were beneficial. Self-help techniques came up, meditation, for example, going for walks, returning to work was something that people felt beneficial as well on the mutual self-help aspect here. Regarding collaboration and mutuality, one thing that was really helpful for people was when providers from various disciplines were working together on a treatment plan, for example. We had someone who said, my primary care doctor, my psychiatrist, they all work together with me and they listen. They don't try to rush you out and they say, okay, time's up and things like that. So again, this idea that you have numerous people who are communicating and working in your best interest. There's also this piece of trauma-informed care about empowerment, about voice, and about choice. My background is in criminal justice, so I'm going to speak about this a little bit from a criminal justice perspective. When people are involved in the criminal justice system, the two parties in the criminal justice system are the person who's the accused, and then you have the state. So in this process, a lot of victims' families will feel that they don't have a formal role. There's a lot of discussion you'll hear about not being heard. And because of that, there's a lot of feeling of needing power, needing say, having a voice in the process. So when we look at this and connect it up with providers in the health sense, wherever we could try to provide empowerment is really important. So this is going to be different for everybody. We have someone who said, we all broke down crying when we saw the photo, but I said I want to see the body because one of my issues was I was in denial. So this is going to be very different for people. This is the same with death scene photos. I've spoken to people who never want to see them, people who do want to see them. So the importance in allowing families and friends of homicide victims to make those choices, make the decision that is helpful for them is important. Providing support information, even if it's not used, was appreciated. There are people who say, I'm never going to use this resource. I really do appreciate, though, that somebody thought to give this to me. And also this individualized approach to grieving. This is going to look different. Everybody's journey is going to look different, and that's something to be aware of also as providers as well. So cultural, historical, and gender issues is the final part of the trauma-informed care. So with these issues, one of the things that's really important is to go back to that statement, what happened to this person? One of the things that came up in our research, which was very powerful, was that the effect that homicide will wind up having on children and the family. And there were children who, even at a very young age, were trying to shield other family members and adults from having to work with their grieving process. So they're bottling things inside, and then they're getting into school and having behavior problems, or they're having health issues. And from an outside perspective, it's, well, this kid, what's happening with this kid? But a lot of times, nobody's asking the question, and, well, there was just a major homicide that occurred. So that was really important, understanding this historical background as well. So we have this quote, there are kids, teens that lost a parent or a brother or sister, and they start acting out, and it's really not because they're bad children or bad kids. It's because they're going through something. So that was really a very powerful statement. Also, this discussion about historical issues, that there might be mistrust with different response systems as well. That's something to be aware of. We have somebody who stated it would have helped to know that somebody cared. I mean, the fact that nobody reached out to us to give us any information, it made us against them. It was the streets against the system. If somebody would have reached out and gave us information, that it was services available, it would have felt a little bit better, like, okay, well, we're not alone. There's additional themes that came up as well that didn't fit into these categories. So we're discussing institutional trauma, a lot of people have already encountered various response systems before they've gotten into the office of working with somebody who's a health provider. I spoke about the streets against the system. Some people felt their lives were not being valued, their loved ones' lives were not being valued, and their loved one being treated like a crime scene at the hospital. Re-traumatization had occurred with circumstances around the death scene. This is, again, about how the memory is important to people, how people were treated at the scene, if people were responsive, and people who already had PTSD had discussed issues about this exacerbating PTSD symptoms. And Dr. Chercheo had spoken before about some of the symptomatology that also has come up with depression, PTSD, substance abuse, chest pains, also shortness of breath that came up as well. And the last set of themes that we have here is about the effect on family units, being aware about non-traditional family arrangements, that there are people who are impacted who might not be blood related or they might not be related through marriage, but this is their family, you know, and this is someone that they want to see, they want to be with, they need information on. Also about community members who are affected. There's also a lot of guilt, impact on children, which we discussed before. Coping we see in both effective and ineffective ways. Some of the ineffective ways is about repression. We had family members, especially if it's a parent, who will have to kind of store their grief, if you will, so that they could assist with their other kids, with their spouses, with the other family members, with arrangement. So they're trying to be strong for everybody else. That's a lot of what people were discussing. Substance abuse, children having very anxious attachment with other family members, being afraid and not wanting to be away from them, and also social withdrawal. We also have here concerns about judgment. Dr. Chercheo will talk about this a little bit with insensitive healthcare providers' comments and inquiries, victim blaming. This is also something to be cautious about because sometimes if you don't get it right the first time, the chance somebody's going to try to attempt again to get health care, to get services, that's going to really impact their motivation to try to go and speak to somebody else. And we also have here learned helplessness. In some communities that are greatly affected by violence, there's these major socioeconomic barriers that you'll hear people discussing about not being able to better oneself. There's not enough opportunities, for example, in communities, and lack of an empowerment as well.
So healthcare providers, we have to recognize where patients are and we need to meet them where they are. And so the work that Dr. Mastrosinque and myself have been doing focuses on the intersection of what has happened to patients, what has led them to where they are now, and what's the way forward, and how can clinicians help and not hurt. Providers need to be aware of past trauma and recognize it can have these long-lasting impacts, and then also link it with the patient's current presentation. So approaching patients using this trauma-informed framework, we think gives a more complete, a more holistic representation of the patient. And this quote from 2001, this lack of awareness can result in failures to make appropriate referrals for trauma services and can result in re-traumatization when a service system's usual operating procedures trigger a reemergence or an exacerbation of trauma symptoms. So if we as providers don't understand that there was a trauma, we can't even attempt to go to the next steps. So some more practical suggestions for healthcare providers. This first slide focuses on the death notification itself. There's the communication in the more immediate circumstance, and then all of those ongoing conversations that we have with patients. So the way the news was delivered was very, very important. Patients generally want a clear, simple message. So going through the technical and medical aspects was not as important, and sometimes using medical language would just confuse these individuals. Their heads are already swimming. They're going through huge amounts of stress. So using simple and direct language seemed to be best. Some people would say, there was one quote, they said, "They told me that he had expired, and I didn't know what that meant." So we need to be aware on our side of how the words that we're using to communicate And then in terms of the circumstance, a lot of us have been trained on how to break bad news. There's a lot of mnemonics. There's the spikes mnemonic, setting, perception, invitation, knowledge, empathic response or silence, and summary. And a lot of those setting the stage involves trying to find a private room, trying to get people sitting. But the fact is that often doesn't happen just in the real world setting. In the hospital, sometimes there are no private rooms available. Sometimes there is no place to get families and friends sitting down to break the news. But that came up again and again in the focus groups. There was a comment about one of the partners of a victim who was she was pregnant and she was leaning against the wall and just kind of started to slump down. So obviously it's something that in an ideal setting you would want to try to make all of these accommodations and consider who is present. That also came up because the people who are closest to the individual who passed away may not necessarily be a blood relative, and being conscious of who is in the room and who you're talking with is also very important. There's this note about suffering. So some of the families and friends of homicide victims had been told that their loved one didn't suffer, and it came up in some of the groups that people asked, well, how do providers know that for sure? So certainly some of the things that we say to people where we think that it may be a comfort, it can sometimes be hard to know on an individual basis how those will be construed. And the interactions with patients, and obviously for all things active listening, empathy are paramount. And it came up several times here, the use of the computer and the electronic medical record. Most physicians don't have a great relationship with our electronic medical record, and it really has driven a wedge between patients and providers pretty much across the board. But in a population that's particularly vulnerable and with these emotionally charged situations, this becomes even more important. So maintaining eye contact, being face-to-face, empathic responses, our body language, all of those really come into play. There was this quote, it's even more important to talk about people about sensitivity because I think technology has gotten in the way. So I used to go to the doctor and the doctor would talk to me, like this. Now he's behind a computer and I'm over there and he's over here, and it's just very disconnected. He really struggles with a computer as well. And again, and this came up again and again. And while we're doing our documentation and typing, there was one participant who said that she had disclosed that she lost a loved one, and the physician just kept on typing. There was no empathic response. There was no connection made with that patient. So again, all of these are things that we need to be aware of, and rushing. So this is emblematic of a larger issue. There's physician shortages, more patients, greater complexity, but it also brings up the fact that there's insufficient support services and insufficient behavioral health resources often to follow up these conversations. We also need to be aware of all the patient's barriers to accessing care. So there can be a disconnect between what the provider thinks the patient needs to do and the patient's reality. So it may involve taking off of work, finding a ride. There could be insurance issues. So there's a chasm there. And also understanding what the patient wants, and again, meeting them where they are. There was a theme at our focus group of feeling more comfortable with peer support groups that Dr. Mastrocinque had alluded to. And along with that, a lot of patients didn't just want a medicine, they often wanted an outlet. And that's where we can be more informed about what resources exist and where we can direct people. And we should also be continually rescreening for trauma and gently bringing it up at different time points, because patients will be in different stages of grief and in a different place when you meet with them. And then there's trust concerns on the next slide, both for providers and for various systems. So, of course, there can be no therapeutic alliance without a trusting relationship. And the patient has to trust the provider, but also the system. And as we spoke about, a lot of times patients have interacted with systems and have not gotten a great response. So there can be a lot of work to be done to build that trusting alliance. And there was concern about being judged. This one individual said they had called a psychologist. I knew right away it wasn't going to work. I said to him, my loved one was murdered, and I'm going through post-traumatic stress. And he said, well, why was he murdered? So that sense of being judged came up again and again. And we often direct our conversations to spouses, next of kin, and of course we have legal and ethical restraints to do so, but we also have to consider that there are these non-traditional ties and that the people closest to the victim may not have legal ties. So we should never underestimate the importance of that relationship. And again, it brings up why we need to be readdressing trauma at multiple time points in our interaction with patients. And we should also keep in mind that we're not seeing people in a vacuum. So we need to be aware of all the multiple systems that they're interacting with, the police, criminal justice, social services, and more deeply the institutionalized socioeconomic inequities. We also need to consider the impact of gender, not only as it relates to family roles, but also in terms of socially acceptable norms for gender behavior. It came up that men were grieving much differently, and for some of the females who were involved in the study, they recounted that that the men in their lives were responding much differently. They were going more inward. They were not expressing it outwardly, and that also has a very deleterious effect. And multiple coping mechanisms were, again, Dr. Mestre-Cinque had alluded to some of them. Some of these coping mechanisms were healthy, some of them were not healthy, and people had alluded to even people turning to substance abuse to try to cope with a loss. In terms of some of our future steps, one of our goals with this project was to build out practical solutions based on the issues that we identified. One of these includes an initiative to train residents in trauma-informed care and to then reinforce that training through simulation sessions. And we also plan to expand this to patient-centered programs and tracking how some of these initiatives will impact patients in the real world.
So for the last slide, I do want to discuss a little bit about the benefits of working with an interdisciplinary research team of practitioners and researchers. So this allowed us to be able to approach the research from various perspectives and also to be able to create questions that are specific to the field, emerging issues as well. So we had these questionnaires. We had prompts for people as well, so it's very helpful to see what would be helpful, especially as we're all in different fields and what we could take back to assist with our own field. Offering different frameworks for analysis as well, and having mental health care providers on the team. Every focus group that we have run, we've had somebody who's a mental health practitioner. Anybody who wants to speak separately about this, I'm happy to, but there are definitely these best practices when you're doing focus groups with people who have been affected by homicide, and having a mental health care provider who's comfortable and trained in trauma, that's very important. I wouldn't do this work without that. And also the practical solutions. So Dr. Traumainformed had mentioned this before, understanding logistics and procedures in various fields. So there's some things that might seem like a solution and, well, why can't this be done? And when you're speaking to people in the field, it's helpful to know, well, there's a time constraint on this, or there's no space to do this. You know, there are no free rooms to bring somebody into. Also, while you're hearing people's stories in the groups, it's also helpful when you have people who are trained in the field to explain what the procedures usually are, what the practitioner is probably doing in that circumstance as well. So those are all things that are really important to have when you're bringing these teams together as well. for the last slides here, this is our works cited. I know that this webinar will be posted, but if anybody wants to contact either one of us directly for this information, I'm happy to provide that. I also just want to note here, too, about the funding, which I know was noted earlier. Again, stressing to thank our participants for sharing their stories, for everybody who's listening as well for your time. And there are two additional people who helped out with this project, Carolyn Gribben and Sue Case. I just want to acknowledge them, too, and thank you for their work on this project. And I will put up also my contact information and Dr. Trauma's contact information as well, in case anybody is interested in getting into contact with us about this work.
All right. Well, thank you both. We do have some time for questions, so I want to remind folks that you can enter your questions in the chat box, and I'm going to go ahead and start. I know, Dr. Trauma, you work at a teaching hospital, and I'm curious, as you all have been talking about this work and what you were learning from the focus groups and trying to raise awareness of the health impacts of the trauma of losing a friend or family member to homicide, what has been the reaction of the other medical providers or the administrators of this teaching facility?
So I think everyone wants to do right by a patient. We all get into this wanting to take care of our patients, wanting to deliver the best care, and then there is the reality of us being pulled in a lot of different directions. And so trying to develop tools that people can use seamlessly that will not be seen as additional work, but rather tools that you can just gather information more quickly, more easily. You can therefore develop better treatment plans, and then you can actually maybe see a reduction in that hemoglobin A1C, a measure of diabetes, or you can see the blood pressure coming down because you're now getting to the root of the problem. At Cooper, we're particularly integrated in our community, and we actually have a very, I think, forward-thinking group of people here who are very, very interested in implementing trauma-informed care and really caring for these type of patients. So it's been very supportive.
Great. Folks, we're going to go ahead and have the exit survey available while we answer some of these questions. So please continue to answer your questions, to ask your questions. And here's one that has come in. How common is it for healthcare settings to include some non-medical staff? Just a moment. There we go. Include some non-medical staff such as social workers or mental health providers on site to facilitate truly integrated care.
So I can take that. So hospitals do have, they have behavioral health counselors, social workers, home health coordinators. There is an interdisciplinary team that's taking care of patients. I think a lot of what we had uncovered in some of our research is really, what's happening in the months and years after some of those initial contacts are made. And I think that's where the health system in general has more work to do to make sure that all of the patients, 5 years later, who may still be mourning the loss of their loved one, but then also has all of these concomitant medical issues going on, to make that connection and see that the event 5 years ago may actually be tied to the unmanaged diabetes that they're coming into your office with. But that's a very good question. So there is integration of services in the hospital setting.
Another question that's come in, what would you advise to advocates who would love to get their local community and their local hospitals thinking along these lines?
Gina, do you want to take it, or do you want me to take it?
I could say something if you want to add on to.
Sure.
So I think part of it might be just diversifying some of the efforts too. So there are, one of my thought process too, we actually just did a separate paper on spirituality after homicide and suicide on a different project, but it's related. And part of the thought process there is that there's people who are very likely to go to places of worship before, if ever, they go to mental health services, whether it's because of stigma or comfort or financial reasons. So I think diversifying and reaching out to some of the local organizations that exist, I think that might be something very beneficial. I think there are a lot more people affected by homicide than I think most people would think. So it's sometimes when you do these efforts too, you're surprised by how many people come forward or are interested. There also might be existing bereavement groups, even if they're not specific to homicide. That might be helpful as well. Funeral directors as well, you might want to contact. So I think maybe trying to work with what's existing and trying to see if you could collaborate with some of the people who might be already in the organization who are working with people who are dealing with the homicide of a loved one.
Yeah, I would echo that. I think if you can find the existing community support systems that are out there, but pull them together so that the information is readily accessible for patients, for families, making it tangible and readily available, and really trying to break down some of the barriers that patients are going to be experiencing is, I think, one of the big roles that people can take.
We did have a tip come in that including local victim advocates as part of the care team could be good because those victim advocates may already have a lot of resources for families, and so just being there as a contact or having those in the healthcare setting include the local advocates. Another question, I don't know whether you know the answer to this, is do you know what the biggest survey of families of homicide victims is, or what is the biggest sample of survivors that you're aware of?
So I think a lot of this work has been done with smaller samples. There are statistics that are captured in criminal justice about homicide incidents that occur. There's a supplemental homicide report that's done, but that's focused on the incidents and not necessarily capturing this type of information to my awareness about people's interactions with the systems. So in short, I don't have a solid answer for this, but I think most of the studies that are being done that I'm familiar with in this area have been smaller sample sizes that I'm aware of. So.
Another question, I don't know whether you all mentioned this or if you have considered this, but do you have any materials that communicate to the friends and family members of homicide the possible health care or health implications that they may see? You know, rather than simply educating the healthcare providers about what to be on the lookout for, a tool or resource that educates the friends and family members of what of the potential. Right.
So,
that's an excellent point. Oh, go ahead, Gina.
Yeah. So I'll speak from the criminal justice side or just our research perspective. The thing that we focused on more in different areas is what's available in the local area for people for support. And we haven't provided anything as far as what to expect afterwards. There are some courts, now I'm talking outside of health effects, but speaking more about the process, there are some places within the U.S. that they will provide information about the process itself. There's some systems that will actually walk people through a courtroom, giving them information about what to expect in the court process. So that's what I could speak to about the process, but I am not familiar with anything about what to expect health-wise after a homicide of a family member occurs. So I'll shift over to Dr. Torcheo if she knows of any additional information.
No, I'm not aware of handouts, but I was going to say that some of the next steps in our research was going to focus more on the patients in the real world, so how they're interacting in their primary care offices and getting care down the road. So I think that's actually an excellent suggestion. We had been talking about putting together resources for them. But again, some of our later steps in terms of our future research was going to be focused on the patients themselves.
This is a great suggestion, too, because I just want to comment that in a lot of people that you work with, families of homicide victims, and this is also similar, I've run focus groups with families affected by suicide as well, that people are concerned about concerns like, am I grieving for too long? You know, when does that process end? And I think that it's really helpful to be with other people who understand that process. And also, like some of the providers will say, to be kind to yourself, too, in the process afterwards. So I think communicating that would be a great idea.
Another question that came in, have you seen any differences where the individual was killed by another family member? Any differences in the effect on the surviving friends and family members if the person who killed their loved one was also a family member?
I don't think we have enough of a diversity in the sample to speak to that. And there's the only, I think, diversity-specific groups that are out there right now. There's a lot of emerging research on cold cases. That's something that people might want to look into. But as far as our sample goes, because it's such a small sample, we can't really speak to that. But the cold cases I bring up because this is something where the process, you know, this is a process where we have families that they don't know who did it, and you know, there's still an investigation going on, and that definitely would impact the process for people as well.
Another question, and I'll just read this because it's a little long. I don't want to paraphrase and miss something. It appears as though the additional theme of institutional trauma may be particularly relevant to populations such as those in your sample, such as Black and Latino, who are repeatedly exposed to both homicide and institutional trauma. Can you say a bit more about recommendations you might make to address this issue in research, policy, and practice?
I think on the provider side, it's making sure that we're actually aware of that. A lot of times when we're seeing a lot of patients, there's a lot going on in the hospital system. Just reminding ourselves of that fact and making sure that what we're saying, the words that we're using, don't reinforce any institutional trauma, that we're not re-traumatizing the individual. I think if you can adopt a more sensitive, nuanced approach, and particularly surrounding some of the things that we had talked about with active listening and empathy and bringing up resources again and again, just making that extra effort with people, I think goes a long way.
Great. We've had so many great comments as well in the comments section. People really appreciating your process and people advising each other on things that have worked in their communities. We'll make sure that those tips are also available for people at the conclusion. I'm just going back through to see if we've missed any other questions.
Can I also, I just
yes.
wanted to follow up on something. I apologize. The person who had asked the question, if they're comfortable contacting me about the larger sample too, I'm thinking there's also some work that's come out of the UK with family members. So that's something, I don't remember the numbers of that too, with the number of the largest survey that's been done. But I'm happy to get that information. If that person wants to contact me directly, I'm happy to get that information to them, because I remember there was some larger scale research being done in the UK.
Thanks. And people did also wonder, when you talk about small scale samples, how small is small? What are you seeing there?
Well, our group it's out of 11 people. So again, because this comes up to people's opinions on what's a small sample. There's some people who do very large scale data sets where you have thousands of people. What's really interesting with these groups is that over the course of years in doing these projects, the same themes are emerging and the same information. There's sometimes you get quotes from somebody that is exactly the same as somebody who you spoke to years ago in a completely different state. it's really amazing to see the consistency. So I think one of the things that we look for as researchers is, what's consistent, especially when you're doing this qualitative work. So I think it's probably an opinion aspect and also what methods you're using. But to us, because we've seen saturation, because of the fact that this is consistent with the other groups that we've done, we're happy in presenting these findings. So.
All right, thank you. I think that's it for the questions, and we have gone just over our time. So I think this is a good place to wrap up. I want to give my sincere appreciation again to both of you for first tackling this understudied area and then sharing with us what you found and giving us hope that there will be even more work in the future that can inform our response to this underserved group of victims of crime.
Thank you so much.
Thank you.
All right. Goodbye, everybody, and we will be sending out the links in the next few days.